Hello, my name is Beth, and this is my critical appraisal of quantitative research design presentation. The study that I chose to review talks about a change in physician rounding style and discharging patients from the hospital in the morning, and how that improves hospital capacity strain. The problem brought up is hospitalist physicians prioritizing discharging patients first compared to the usual rounding style of rounding on everyone and then discharging later on in the day. The purpose statement is to relieve hospital capacity strain. Hospitals often encourage clinicians to prioritize early morning discharges, which may have unintended consequences. The purpose statement relates directly to the problem. Question number 4, what are the dependent and independent variables? So this study called their variables explanatory and response variables. The explanatory variable is the independent variable. It is the variable that is manipulated, changed, or used in a study to explain or predict changes. And in this study, the independent variables are the rounding style of the physician and the discharge time, meaning the time of day that the patient is discharged. The dependent variable is the response variable, which in this study would be the hospital capacity strain. Question 6 asks, of the 3 terms, how did the study demonstrate or fail to demonstrate each term? This study is classified as a randomized controlled trial. The study split the physicians randomly into 2 groups. One group prioritizing discharging patients first as care allowed, and the second group demonstrating usual practice of discharging after their rounding was complete, typically later in the morning or early afternoon. The control group, being the physicians assigned to the group following usual practice, there was no manipulation that I discovered reading through the study. The study was very well put together and completely randomized regarding how patients were discharged from their inpatient stay. The study was all based on quantitative data that was collected. Question 10 asks to discuss the sampling aspect of the study. The sampling method used in this study was simple random sampling. This study included hospital medicine attending physicians who consented to participate in the study. To ensure randomization, physicians were approached by members of the research team that were not in direct supervisory roles, primarily by email after it was presented to the hospitalists during their team meetings. Physicians were recruited on a rolling basis. While the initial plan was for physicians to participate for 3 months, the full duration of the actual study period lasted for 6 months to account for the rolling recruitment, meaning that the physician could enroll in the study at any time up to a certain point. Recruitment prioritized clinicians with 75% or higher clinical time to ensure they had sufficient numbers of discharges and patient care activities. Patients included patients the physicians cared for during the study who were at least 18 years of age, admitted to a medicine service, and assigned by standard practice to a hospital's team. The sample size included 3 hospitals, including one being a 678-bed quaternary care center with approximately 12,000 medicine discharges per year with 75 hospitalists. The other facility that was included was a 550-bed safety net hospital with approximately 10,500 medicine discharges per year with 39 hospitalists, and a 420-bed academic medical center with approximately 11,000 medicine discharges per year with 40 hospitalists. One hospital is located on the East Coast, and the other 2 are located in the western region of the United States. They are each in separate healthcare systems as well. There really wasn't a specific response rate, but for the entirety of the study from February 9th, 2021 to July 30th of 2021, patients were discharged by 59 physicians. This sample size was adequate for the study being completed because it had a large sample number greater than 4,000 participants. But never specifically stated the results were with 95% confidence due to there not being a significant difference in the results. There were 0 physicians that dropped out of the study, at least that none were stated, which I think with it being a rolling recruitment helped with this aspect of the study. Question 14 asks about major findings and conclusions of the study. After almost 6 months of data collection, 4,437 patients were discharged by 59 physicians. The findings of the data showed no significant difference from discharging patients earlier or reducing the length of service. These results honestly surprised me. At my health system right now, on my unit, we are working on getting patients discharged earlier in the day and also out quicker once orders are signed to improve hospital throughput. We have always had the goal that the patient is to be discharged within an hour from the time that the orders are signed and then completely out of the system within 30 minutes of the patient being discharged. So from the time that the orders are signed to the time of patients taken out of the system, roughly an hour and a half. Over the last month, we have kicked our efforts into high gear and are getting patients out the quickest that I have seen this happen in years. And we are also getting them out of the system in record time as well. As a charge nurse, I have seen much improvement in our new workflow with it getting individuals out of the emergency room and to the unit to a hospital room much quicker. But regarding our change affecting the length of stay or the level of service, I have not seen a visible change in that, but that doesn't mean that the data doesn't show it. I just haven't seen the data. And that is all. Thank you.